Thank you for joining Cancer Support Community Atlanta for Pelvic Floor Disorders, facilitated by Dr. Alexcis Ford with Advanced Gynecology and moderated by Mira Merille with Northside Hospital. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to Pelvic Floor Disorders. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, where you can see all the free oncology support services offered virtually, which range from virtual support groups to monthly oncology nutrition seminars. And if you miss a live event, you can find a recording available under the video library on our website. Again, that's cscatlanta.org. Everyone will remain muted throughout the presentation. We invite you to enter questions into the program chat box, which will be addressed during the Q&A at the end of the program, time permitting. I want to welcome today's program moderator, Mira Merille. Mira is a board-certified specialist in women's health physical therapy. She has over 5 years of experience specializing in the treatment of pelvic floor dysfunction. Mira is highly skilled in the treatment of urinary and fecal incontinence, pelvic pain, sexual dysfunction, pelvic organ prolapse, voiding dysfunction, and constipation. She prioritizes individualized, evidence-based care to each of her patients at Northside Hospital in Atlanta. And with that, welcome Mira, and I will go ahead and pass it off to you to introduce today's presenter.
Thank you so much, Katie. Thank you everyone for joining us today. I'm so excited about our presentation ahead. We have the incredible Dr. Ford speaking on pelvic floor disorders. A little background on Dr. Ford. Dr. Alexcis Ford is board certified in obstetrics and gynecology and board eligible in female pelvic medicine and reconstructive surgery, urogynecology, female urology. She is a Harvard-trained urogynecologist, female pelvic medicine, and reconstructive surgeon with advanced gynecology. Dr. Ford has extensive experience with both surgical and non-surgical treatment of a wide array of pelvic floor disorders. She also specializes in the management of pelvic pain, including vaginal mesh removal, as well as treatment of fecal incontinence and rectovaginal vesicovaginal fistula repairs. Dr. Ford is passionate about providing holistic, women-centered care to her patients. All right, I'm going to pass it to Dr. Ford for our presentation.
Thank you. Thank you so much, Mira. And thanks everyone for joining. I know this is a bit off the beaten trail, maybe, in terms of what maybe Cancer Support Network usually does, but I really am so appreciative of the opportunity to talk about something that is so common. And, you know, because it's so common, it certainly affects women who have cancer. And specifically, I'll talk about gynecologic cancer a little later on in the presentation. But I think for what we're trying to accomplish today, first, I'll explain sort of what I do. That's a lot of my job, is just to explain, you know, where a subspecialist like me kind of comes into play in patient care. We'll talk about what pelvic floor disorders are, or PFDs. In my bio, as you heard, there are a lot of different things that I do, but I just want to briefly talk about two sort of bread and butter types of pelvic floor disorders that I treat, and, you know, very briefly what their treatments are. And then we'll dive into the impact of gynecologic cancers on pelvic floor disorders, because they certainly have some interplay. And then talk about what the role of the cancer patient and a clinician is in terms of identifying and treating pelvic floor disorders. So first off, what is a urogynecologist? So you may have heard a lot of different words: female urologist, urogynecologist, female pelvic medicine and reconstructive surgeon, or FPMRS. There's a lot of names because basically this is a newly designated specialty. As of 2013, it was identified as something that you could get a board certification in. For years, either urologists or gynecologists were sort of doing pelvic floor reconstruction, but they formalized this several years ago. So to become a female pelvic medicine and reconstructive surgeon, you either need to be trained in obstetrics and gynecology or urology. So urologists can also become a urogynecologist, but you must have subspecialty training after that. So that's either a 2 or 3 year fellowship. And in that time, you sort of subspecialize in surgical and non-surgical management of pelvic floor disorders. So as an OBGYN who's trained in urogynecology, I don't do babies anymore. I don't deliver babies. I don't do any obstetrics. I don't really do general gynecology that much anymore. You know, if I have a patient who has maybe some abnormal bleeding or something that is within the field of gynecology, but not necessarily urogynecology, I'll manage that. But typically I just specialize in pelvic floor disorders. And I just wanted to make it clear that urogynecologists don't manage cancer. We don't diagnose cancer. We don't treat cancer, but we work together a lot of times with cancer surgeons and medical oncologists to take the best care of our patients who happen to have cancer also. So what are pelvic floor disorders? So pelvic floor disorders are a group of disorders that affect the pelvic floor due to weakened pelvic muscles or tears in connective tissue. So this is sort of a catch-all of a bunch of different types of conditions, and these are some listed below. Overactive bladder or urgency frequency, that's an extremely common one. Incontinence, urinary incontinence, leaking urine, that's either with urgency or with cough, laugh, sneeze, that sort of a thing. Fecal incontinence, so leaking stool, and fecal incontinence also encompasses leaking gas as well. So accidental bowel leakage is another word for that. Pelvic organ prolapse, or the feeling or the visualization of something coming down, coming out of the vagina, whether that is the bladder, the vagina, the uterus, that all is encompassed by this term called pelvic organ prolapse. Genitourinary fistula, or even rectovaginal fistula. These are abnormal connections between the vagina and the bladder, or the vagina and the rectum. And we can see these particularly in patients who've had surgery before, cancer surgery, radiation for their surgery in their pelvis. That is something that we can see and manage. Chronic pelvic pain, interstitial cystitis or bladder pain syndrome, and then complications with mesh. Those are all encompassed in what a urogynecologist treats and what pelvic floor disorders are. So what is the prevalence of pelvic floor disorders? So a quarter of women in this country will have at least one pelvic floor disorder. So I sort of put them in order of kind of the top 4 and most common to least common, but overactive bladder overwhelmingly is the most common thing. We see that urgency, frequency to urinate, stress urinary incontinence, or that's leaking with cough, laugh, sneeze, exercise, intercourse, that sort of thing. Fecal incontinence, as I've talked about, and pelvic organ prolapse. We know that the prevalence of PFDs increases with age, and nearly half of women have at least one of these pelvic floor disorders by age 80. 1 in 8 women will have a surgery for this by age 80, so it's very common. What are some of the risk factors? So this is a bit of a busy slide, but as you can imagine, this is not just, one day you wake up and you're peeing all over the place. This is kind of over the years, some life circumstances, some medical circumstances, surgeries, babies, all of these things kind of come into play. So we know increasing age, increasing BMI or weight, estrogen status, so whether or not you're menopausal or premenopausal, that definitely matters. How much activity you like to do, what your physical activity entails, really heavy lifting, that type of stuff can increase the risk of prolapse in particular. What surgeries you've had before, so particularly gynecologic surgeries like a prior hysterectomy, cancer surgeries, radical hysterectomies for cervical cancer. Those things can become risk factors for PFDs, as well as a history of a urogynecologic procedure as well. orthopedic surgeries, neurologic surgeries, all of those things can affect the nerves that lead to the pelvic floor. Medical history, this again kind of goes into some conditions that can affect the nerves in the pelvic floor. So we know diabetes can definitely do that, neurologic disorders like multiple sclerosis, chronic increases in abdominal pressure. So this is, people with asthma, allergies, lung disorders where they're always coughing or sneezing, that can definitely increase the risk of damage to the pelvic floor and developing a pelvic floor disorder. And again, radiation as well. Smoking is a big part of this too. Of course, we know having babies while it's wonderful, it's not great for your pelvic floor. So certainly the more babies you have, the bigger babies you have, whether or not you needed a forceps to deliver your baby, if you had a very bad tear, sometimes all the way down through to the anus, that can cause definitely ramifications later on in life with the development of pelvic floor disorders. So this is where we'll just talk briefly about a couple types of pelvic floor disorders, just to kind of give more context specifically into what we do. So let's talk about overactive bladder, the most common of the ones that I mentioned. So the definition is urinary urgency with or without incontinence, often associated with frequency as well as nocturia. This is a nice little slide that just goes into sort of the elements of overactive bladder. So urgency is just a very sudden, strong desire to urinate that may also be associated with leaking urine before you get to the bathroom. And some people ask, how do I know if I'm going to the bathroom too much? And, while there's this number here, 8 or more visits to the toilet within 24 hours, I think what's more helpful is actually if this is kind of interfering with your life, thinking about needing to find a bathroom, getting to one, that sort of a thing is a little bit more important than the actual number. And then nocturia. This can be really, really troublesome, waking up at night to urinate. So you consider, waking up once at night is probably normal, but 2 or more times while you're sleeping can typically get pretty disruptive and is a part of the definition of overactive bladder. How does this affect our quality of life? It often leads to a lot of needing to plan, making sure you have extra clothes, perhaps wearing darker clothing, doing something called bathroom mapping, where basically before you go anywhere, you need to locate where the bathrooms are in order to make sure you don't have an accident. You have kind of a quick exit strategy if you have to get to the restroom quickly. Skipping social activities, missing social events because you're worried about not being able to get to a bathroom or perhaps smelling like urine. That's something that can be pretty devastating. Limiting fluids because you don't want to create urine and perhaps leak or need to go to the bathroom. That can lead to dehydration and hospitalization sometimes. Chronic fatigue because you're having to get up at night multiple times to go to the bathroom. And then social isolation is the ultimate sort of culmination in all of these things. It's just not wanting to leave the house because you really are being managed by your bladder. So what are some of these treatment options? So there are 3 lines of treatment. So the first line here, this isn't medicine. These are just things that we can absolutely manage non-medically initially. So lifestyle changes. So keeping good track using a bladder diary. When are my worst days? What are my better days? What's different about those days? Bladder retraining. This is a concept of, it's almost like your bladder is like a pet dog. It does sort of what you want it to do if you're pretty consistent about training it. So for example, if your bladder is waking you up 10 times at night, if you reward that and get up, 10 times, it doesn't really get the signal that that's not appropriate. So there's a lot of psychology, physiology that goes into bladder retraining. Timed voiding, or just making sure that you're emptying your bladder at regular intervals to make sure it doesn't get over full and you're having leaking as you're getting to the bathroom. improving your diet or removing dietary irritants from the bladder, things like spicy foods, citrusy foods, caffeine is a really big one, alcohol, artificial sweetener, those sorts of things. And pelvic floor exercises. So we have an expert here in Mira. There's some element of this that can be done on your own, but ultimately, there are people who are experts in this. And, if you're not doing these exercises correctly, you can cause some damage. So I always recommend visiting a pelvic floor physical therapist as a first-line treatment for overactive bladder. Second-line treatment options, this is what sort of we think of more, but these are just pills, medications. There are really only two types of medicines for how common a disorder this is. There haven't been a whole lot of advancements in the medical, meaning in the medication field of this. There are some issues that we run into using some of these medicines for bladders, but basically for overactive bladder, the concept is the medications are designed to relax the bladder and allow the bladder more opportunity to fill before that urgency is felt. However, there can definitely be side effects. The receptors that these medications bind to on the bladder, they can also be located in other parts of the body, like the eyes, the mouth, the GI tract, even the brain. And so we can see unwanted effects elsewhere, like dry eye, dry mouth, fogginess, mental fogginess, sort of constipation as well. These are some issues where, sometimes medications just aren't appropriate for people, and we just have to skip the second phase. So it's definitely a conversation to have, and within the realm of a primary care practitioner, really first and second line treatment are within their purview. But where a specialist often comes in handy is the third line treatment options. So these are procedures. These are where, you've tried all of the first line stuff, you've eliminated caffeine, you haven't had, alcohol in forever. You've tried a couple different types of medications, nothing has worked. Then you see us. So this is where we talk about interventions, and most of these interventions are they're predicated on the fact that the nerves that are going to the bladder are too sensitive, kind of hyperreactive, and how do we calm down these nerves? So I'll go through these three sort of options here. So the first one, bladder onabotulinum toxin A. So what this is an injection of onabotulinum toxin A, or Botox is a trade name for this. It can be done in the office. It can also be done with light sedation in a procedure room where a camera is placed in the bladder. A flexible needle is placed through the camera, and in 20 different areas in the inside of the bladder, there's an injection that's made of a small amount of this onabotulinum toxin A to help basically paralyze the muscle in the bladder, just like it does in the face for cosmetic procedures, or in the neck or the head for migraines. It's exactly the same medication, just used in a different application. It takes a couple weeks to start to work. And just like when it's applied in other areas of the body, it does wear off. So you do have to have recurrent injections of these. But data shows that it does work pretty well, and that it is really well tolerated as a minimally invasive procedure. Moving on to the second option in terms of third line therapy is a posterior tibial nerve stimulation, or PTNS. Think of this as like electroacupuncture. So basically, I'll go into this little picture. It's an office visit where, if you look down at the bottom of the slide at the patient's ankle, there is a little needle. It's thin, like an acupuncture needle, that's placed just behind the ankle bone, and it is aligned near, not on, but near the posterior tibial nerve. You can see the pathway of the nerve that goes up the leg and sort of travels alongside the bladder. We know that when we give that nerve a bit of a charge, it can calm down the bladder. So what we do is we connect that acupuncture needle to a little device that has a battery in it, and that battery delivers that charge. You sit in that chair for 30 minutes, and you do that for every week for 12 weeks. So it's a bit time intensive, but you do have to be in an office. Sometimes you have a lot of other people who are in the room with you having the same therapy done. But after 12 weeks, certainly after 6 weeks, we expect to see improvement. But after 12 weeks, we then switch to maintenance therapy, which there's not really an accepted sort of practice of that, but something like once monthly for a few months is typical. The third option in third line therapy is something called sacral neuromodulation. I think about this like a pacemaker for the bladder. It's literally the same technology. A pacemaker for the heart is basically a battery connected to a wire. The wire is implanted near, muscles and nerves in the heart to help sort of calm down the heart when the heart starts kind of beating crazy. It's the same concept in the bladder. We just don't put a battery in your chest, we sort of put it in the upper buttocks. And we connect that battery to a wire, and the surgeon will place that wire using either landmarks, so just by feeling the back, or by x-ray guidance through something called the S3 foramen. That's just a hole, one of the holes in the sacrum, the backbone. The wire that we put in it has these 4 electrodes that we can give a charge with the battery. And the location of that wire is just along this S3 nerve. That's the nerve that goes to the bladder. And we know, again, by giving that nerve a charge, it can calm down the bladder. The wire itself stays in there. The battery does die after a while, and that needs to be replaced every 5 or 15 years, depending on the type you choose. And we do kind of a temporary test phase where we see if the technology works. We don't have to implant anything in you. We just use a temporary wire and a temporary battery. And for a couple, 3 days or so, we see if you've had an improvement, and if so, we move on to the placement of the permanent lead and the battery. So that's sort of like a quick overview about overactive bladder, which is very common. And I think it's important to talk about because a lot of people, after the medication phase, they sort of just say, well, I guess this is something I have to live with. And that's not true. So talking about a second very common disorder that urogynecologists deal with, pelvic organ prolapse. So this is just defined as the weakening of the levels of support of the pelvic floor, resulting in a symptomatic, either palpable or visible, meaning you can see it or you can feel it, a bulge from the vagina. So this is just a quick chart about all the different kinds of prolapse that can occur. So the little ball that you see kind of coming out of the vagina, it can be any one of these things. So a cystocele, you can see that this is kind of a person cut in half. We're looking at their bladder sort of on the left side, and you see the prolapsed bladder sort of coming down and creating a bit of a bulge in the vagina. But relatively speaking, the location of the uterus and the rectum is normal. And we see kind of the converse of that, a rectocele, where the rectum sort of bulging into the vagina, but the rest of the organs are in a normal position. Similarly, with uterine prolapse, we see the bladder's in a good spot, the rectum's in a good spot, but the cervix and the uterus are coming down significantly. And this can even happen. This is a point I kind of want to harp on. This can happen in people who've had a hysterectomy. So it's not that the uterus is the problem, and I hope that this demonstrates it. The uterus is kind of like just an innocent bystander in all of this. It is the support for the vagina that's weakened. So if you have a weakly supported vagina, even the skin on the vagina can come down. So it's almost like a sock, like turning inside out, that it's not an issue with the uterus. So some people say, well, I'll have a hysterectomy for whatever reason. It might be cancer. That's going to treat my prolapse. It won't. You need a prolapse procedure to treat that. So when we talk about what are the treatments, you don't have to have surgery. There are certainly conservative options for this. So again, harking back to Mira, pelvic floor physical therapy, super essential. And I say even for my patients who've had surgery, a reconstructive surgery, it's like, great, I fixed it. It looks, you know, how it should look, but that doesn't mean it's going to stay that way. You really need to maintain the strength and the integrity of those muscles and those ligaments. And that's where physical therapy is super, super important. Even, you know, beyond just the structure, the function of a newly reconstructed pelvic floor is sometimes odd to get used to, if that makes sense. You're so used to urinating in a certain way. You're so used to having bowel movements in a certain way. Now your anatomy is completely different, and you almost have to relearn how to do those things in a safe and normal way. Pelvic floor physical therapists are experts in that. Using vaginal estrogen cream, so that can really help increase, you know, the integrity of the pelvic floor muscles, the fascial layers, super important there. And pessaries. So this is a picture of a couple different types of pessaries being used, but basically, in a nutshell, the pessary is a rubber device that you are fit for specifically. So you come in for a fitting to get the right shape, the right size. It basically just sits in the vagina. So these little blue structures here sit in the vagina and lift that bulge away from the opening of the vagina. The only time you'll feel a bulge is as it comes close to the opening of the vagina. You don't feel anything once it's deeper inside. And that's what this pessary takes advantage of. It doesn't repair anything. It doesn't reverse, you know, the prolapse. It doesn't prevent it from worsening. It literally is just like a Band-Aid, and it helps you feel better, you know, while it's in there. So in terms of surgeries, there are multiple different types of surgeries for the same condition. And so it sort of is always going to be a conversation between, you know, the patient and the physician in terms of what surgery makes the most sense. But as you can see on the left, there are different options here. We don't have to use mesh for surgeries. That's called a native tissue repair. But sometimes we do use mesh. That's the mesh repair. We don't always have to, you know, make incisions in the belly. We can often just go through the vagina. But sometimes we do use a camera or a laparoscope and repair things sort of from the top. We also don't have to take the uterus out. Certainly if there's cancer or something like that, you know, it must come out. But strictly speaking for prolapse, as I said, the uterus is kind of just the innocent bystander. Sometimes from a technical standpoint, to do the procedure, the uterus has to come out, but oftentimes that's not the case. So the picture here on the right side is a depiction of one of the most common prolapse surgeries that we do. It's called a sacrocolpopexy. You can see this is sort of the same woman cut in half just from the side. If you're looking at the vagina, you see this mesh that's sort of shaped like an upside down Y. The front of the mesh is placed on the front side of the vagina, so between the vagina and the bladder. The same thing is done on the back side between the vagina and the rectum. And then the tail of the Y is tensioned or kind of tightened in such a way that the vagina takes a normal course. It has a normal tightness, so it's not too tight. You know, so as you say, that's like a trampoline vagina. You don't want that. You want it to be normal. And so that's kind of where some of the art comes into this, because there's no measurement for that. It's just sort of by experience. And we connect that side of the mesh to a ligament that's on the tailbone. So it's not connected to bone, but it's connected to a ligament on the tailbone called the anterior longitudinal ligament. It's the strongest ligament in the body. So that is one way we do surgery. And the way that we approach this is not with a big belly incision, but it's with small, minimally invasive incisions on the belly. This is a couple views of native tissue repairs where we don't use mesh. But the top view, this is something called a uterosacral ligament suspension, where basically we lift up the top of the vagina and we connect it to your own structures called the uterosacral ligaments. There's also the bottom procedures called sacrospinous fixation, where this is again all done vaginally, where we attach the top of the vagina to this ligament, very strong ligament called the sacrospinous ligament, always stitches and no meshes involved. So lots of various options. And that's why urogynecologist is important to see, because fellowship training and subspecialty training allows for a much wider skill set, a lot of different ways to sort of accomplish the same goal, but be able to tailor it to the patient in front of you. So we'll talk a bit about pelvic floor disorders in gynecologic malignancy. So this is from a nice little paper that just tried to identify, we know pelvic floor disorders are common. Like we said, 25% of women in this country have it. Half of women, by age 80 have at least one pelvic floor disorder. We wanted to see if we could, quantify how many of these women who have cancer also have pelvic floor disorders. And basically, we know that it's similar, if not more, to the general population. So this on the left side here, a pelvic floor symptom, any urinary incontinence. If you look at the top row here, where they stratify between all types of cancers, just uterine cancer, ovarian, cervical, and vulvovaginal. If we look at an aggregate, anybody who'd had any urinary incontinence, it's about 41% of people with cancer. And we can see that the frequency here, or how much bother, is sort of separated. But in general, almost half of the women in the survey who were cancer patients had some urinary incontinence. They further subdivided by stress incontinence. We see that sort of a mixed bag, but stress is a little bit more common than urge in this study. And here, fecal incontinence, it's much less common, but we certainly do see that this reflects basically the general population. About 2 to 3% of patients do have fecal incontinence. And there was no difference in terms of the types of cancer and the frequency of these things. This is a systematic review of, basically they looked at 550 papers, and 31 manuscripts qualified for inclusion in the systematic review of looking at pelvic floor disorders and GYN cancer survivors. So basically, when stratified by different type of cancer, cervical, uterine, ovarian, and vulvar cancer, we do see that, stress incontinence, it kind of just depends in terms of the type of cancer and how that cancer is treated, and whether or not their symptoms got sort of better or worse. But in general, we typically find that these pelvic floor disorders get worse after treatment of cancer. And that sort of goes back to the risk factor slide, which showed that surgery for gynecologic malignancies is a risk factor for pelvic floor disorders. So not only do women have these at baseline, then are diagnosed with cancer, it's the treatment of cancer can also kind of contribute to pelvic floor disorders, whether or not that's radiation or pelvic surgery, like a hysterectomy, oophorectomy, things like that can definitely contribute. In general, though, it should be said that study in this area is not robust at all. So that systematic review is one of very few to look at this specifically. And even the papers that were included in that study are all considered sort of grade C evidence, so not very good, not randomized control studies where we really can try to approximate cause and effect as much as possible. We don't really have those types of studies in this field. The most studied sort of correlations between cancer and GYN cancer and pelvic floor disorders are with cervical and uterine cancers. And unfortunately, with ovarian cancer, there's almost no data. And the thought is that it's probably because it's a more aggressive cancer, and it's just the focus is really not going to be on much else besides ovarian cancer. I will say, before I move on from ovarian cancer, one of the papers in this field is a paper of mine from several years ago, where we took care of a patient who happened to have ovarian cancer and had recurrent ascites, so was developing a lot of fluid buildup in the abdomen. And because of that, the pressure was really pushing down on her pelvic floor and causing a massive bulge that was more symptomatic to her than the ascites. And so, operating on that patient, of course, it makes sense. Primarily, how do we prevent the ascites? That's the number one thing. But, the symptomatic improvement from having a pelvic floor repair really helped her. So we published the way that we did that. In terms of cervical cancer, we know, as I mentioned before, radical hysterectomy is associated with more urinary incontinence than, for example, a nerve-sparing surgery. So that makes intuitive sense. If you disrupt a lot of the nerves that go to the bladder, it just doesn't act normally. And so if you can spare the nerves as much as possible, it's helpful. We know that radiotherapy is associated with higher rates of urinary incontinence, urgency urinary incontinence especially, as well as fecal incontinence with cervical cancer patients compared with those who were just treated with surgery. And we know that in terms of when these things develop, surgery is usually associated with higher rates of immediate pelvic floor disorders like urge incontinence or urinary retention. But radiation therapy usually shows up in terms of side effects later on with more delayed findings in pelvic floor disorders. In terms of uterine cancer, we have the best data from long-term follow-up of a Portec trial looking at brachytherapy and radiotherapy for uterine cancer. And we know that both of these groups had really high rates of urinary incontinence, vaginal dryness, urinary dysfunction. So in general, as treatments for gynecologic cancers are getting better and people are living longer, cancer survivors are going to be having to deal with a lot of these pelvic floor disorders. So being able to recognize those and route to appropriate treatment is important. So in terms of when we see a patient who happens to have a gynecologic cancer, what are some special things that we consider for these patients? So I just kind of bullet point listed some of these things. Of course, sometimes the conversation is, maybe this isn't the appropriate time to treat this. You're in the midst of chemotherapy. Maybe here are some minimally invasive, some minimal intervention things that we can do that don't necessarily involve surgery, where, concern for healing and things while on chemotherapy would be an issue. So seeing a pelvic floor PT, that kind of thing, we can certainly initiate treatment. Sometimes it's the opposite, where we really need to expedite care because we're on sort of a strict window, maybe chemo's ending and we kind of have to get in a window where we can do surgery where counts are the best. Sometimes facilitating a coordinated surgery where, for example, for uterine cancer, somebody who also has stress urinary incontinence, if we can coordinate with the oncologic surgeon about, while you do their hysterectomy and remove their ovaries for their cancer, at the same time, I can be there to place a little sling underneath the bladder neck to help prevent, that unwanted leakage after surgery. That is something that we're really used to, that we're really flexible around, and we'll sort of, have privileges at a bunch of different hospitals kind of for this reason, to just be available for the patient that might need us. Of course, there are sometimes interventions that just are not appropriate for a patient with cancer, and talking about alternative options for those patients is really important. And again, having really good relationships with medical and surgical oncology, GYN oncology, to just foster the best relationships and have the best care for our patient as a whole, and not necessarily just a cancer patient or just a urogyne patient, knowing that these folks have things that coexist. So just quickly looking at some of the studies of this. So one study looked at patients with endometrial cancer and stress incontinence. This is sort of the scenario that I just posed. It was published in 2019, where they looked at 500 patients with some form of precancer or early endometrial cancer who also had leaking when they cough, laugh, sneeze. And they looked at the quality of life in the patients who had a surgery just for their cancer, or who at the same time as their cancer surgery also had their incontinence addressed. and their quality of life was significantly increased when they had both things addressed at the same time. Other kind of considerations that we've talked about, patients who maybe have a form of an estrogen sensitive or hormonal sensitive cancer. Many of these patients are either artificially put into menopause or are already menopausal and have something called the genitourinary syndrome of menopause, which basically encompasses genital symptoms like vaginal dryness, sexual symptoms, pain with sex, and urinary symptoms like urgency, frequency, incontinence. So in general, for patients who have hormone-sensitive cancers, we do non-hormonal treatment first. So different things, moisturizers, lubricants, topical anesthetics like lidocaine. A lot of times that is, the scope of the use of those things is pretty limited. But, we try our best first. Of course, if we can avoid hormones, we do. But we know that with a specific regimen of vaginal estrogen, circulating levels of hormones are typically low. Of course, it is possible to misuse or overuse these types of treatments, and then it's hard to control exactly what's going on in the blood. But vaginal estrogen cream comes in lots of different formulations, and we know that low dose of these vaginal estrogens is not shown to cause a sustained elevation in the amount of estrogen in the blood, above the normal level seen in postmenopausal women. That being said, it's not really clear what that threshold is, what level of estrogen is going to be, risk factor for recurrent cancer. So because there's some ambiguity, we don't make these decisions in a vacuum. We'll always, it's sort of shared decision-making with the patient as well as often as I can. If a patient has a medical oncologist, I will always reach out to them before putting anyone on vaginal estrogen. So it's important to definitely, keep this type of relationship active between providers. So kind of wrapping up, what are some of the take-home points, for the provider? Really trying to screen for these conditions in the patients that you're taking care of. It takes 30 seconds to ask a question, and it's not as though you have to treat the answer. Just send them over. We work really hard to see patients the same day if we need to. Do you have any bothersome bowel or bladder symptoms like urgency, frequency, loss of control? Do you feel a bulge in the vagina? Those are things we can often fix at the same time as their cancer surgery. And then, of course, get to know your local urogynecologist. There aren't a lot of us, so there's usually only a few in the area. And it's important to try to get to know, your allies as much as possible. And that's, part of why I do things like this is to just, make sure that we are available and people know about us to know that, we're here to take care of the patients. And then, of course, take home points for the patient. Advocate for yourself. Some patients are awesome at this, and others are more apprehensive. And I think when it comes to having a cancer diagnosis, it can be sort of, tunnel vision. And a lot of times that's completely appropriate. But sometimes, we can broaden our scope a little bit and sort of kill two birds with one stone, as it were. There's also a really lovely nonprofit website called voicesforpfd.org. This is not specific for cancer patients, but these are patients who have pelvic floor disorders of any kind. To find, a local urogynecologist, maybe if your provider doesn't know one, they have lovely patient education resources. A lot of the photos and pictures from my presentation comes from their patient education. So that's those are sort of the take-home things here. So that's me. That's how you can find me. I see patients in a couple areas, Alpharetta and our Buckhead office. You can book appointments online or give us a call. Even if you just have questions, it's good to ask. And thank you. I want to thank everybody for the opportunity to chat. Those are my references. I appreciate it. I'll take any questions.
All right. Thank you so much, Dr. Ford. That was so incredibly informative and enlightening. I'm sure most women either can relate in some respect or know someone that is dealing with something. So I'm looking forward to getting to the questions. We have quite a few good questions ahead, but I do want to highlight some of the resources from Cancer Support Community. So I want to let you know that Cancer Support Community has so many resources available. They are all free, and right now they're all virtual, meaning you can access them from your home. They have support groups, stress reduction classes, so that includes yoga, tai chi. They have chair yoga, gentle yoga, monthly nutritional seminars, and education programs like this one. If you've missed any of the previous education programs, you can check out their website. They're all on there, and that is at cscatlanta.org. And if you want to register for any upcoming classes or programs, you can do that on the website as well. I do want to also let you know about rehab services provided by Northside Hospital. Northside has physical therapy, occupational therapy, lymphedema therapy at many locations. We're in Atlanta, Alpharetta, and we also provide services through Sovereign Rehab. So you do require a referral, but we are happy to see you. All right, let's get to some questions. So I really like this one. I think it's great to arm yourself with preventative measures. So Dr. Ford, are there any preventative measures that can be taken to avoid pelvic floor issues that come with aging?
Wonderful question. And I think, Mira, you probably love this because my, pelvic floor physical therapy is just really, I can't say enough about these wonderful people who do, I think, God's work, because it's a field that a lot of people don't know about, first of all, but I think they're so undervalued in general. And I'm very frank with a lot of my patients. There's some stuff that you just don't need a surgeon for. A surgery is not the answer here. You know, that's not what will help. And I think from a preventative standpoint, even, you know, better techniques of how to eliminate, you know, how to void, how to have normal bowel movements. I think we are all so used to what we do normally that we don't know what we don't know, you know, and a lot of times my conversation is just like, yeah, you really shouldn't be pushing when you have a bowel movement. And some women are like, what are you talking about? I've done that since forever. And, you know, that's why they're in my office, because that is not actually how your pelvic floor is designed to work. So, you know, certainly I think from a preventative standpoint, you know, pelvic floor physical therapists are super helpful. The other things to sort of think about are lifestyle, kind of general basic things, obviously healthy diet, eating well, you know, the stuff that's within your purview. There are some types of specific physical activities that we know are kind of especially bad for the pelvic floor. You know, whether or not those things are avoidable is definitely the other question. But, you know, super heavy lifting in the gym, deadlifting, you know, maxing out every rep, you know, deep squatting while you're doing this heavy lifting. That is, if that's not your job, if you're not a deadlifter as your job, I would try to change up your routine a little bit. That's another sort of point that I think is missed a bit. Changing up a physical activity routine is super important for so many things in your life, but especially if you're doing something one day that's constantly stressing the pelvic floor, if you don't come back to that for the next week, it's probably fine, you know, but if that's the thing you do every day when you go to the gym, it's probably not great. But to be honest, the person who will tell you about those things is a pelvic floor physical therapist. So you can sort of just knock it all out there by seeing them. And, you know, in general, just taking care of your health from a preventative standpoint by seeing, you know, an OBGYN or somebody who does a routine physical exam on you including a pelvic exam every year is just basic. So that's definitely something you'd want to do.
Awesome. Yes, thank you for the shout out. I probably do a lot of education like yourself. As you mentioned, not straining for a bowel movement. I have to say my big pet peeve is please sit down to urinate. Don't hover, clean it, do whatever, come armed with whatever you need to do, but you have to sit. All right, so this is another question that was submitted by a participant. How can you tell the difference between a pelvic floor dysfunction and recurrent UTIs? Can they be related?
Such a great question. So when you say, how can you tell? A lot of times it's not the patient that can tell. It's sort of for a specific chain of events to happen. Number one, as a patient, you have symptoms of a UTI. What should happen, and I wish this happened more, is, you call your doctor and the doctor says, okay, great. Let's have you come in for a urine sample and let's see, if there's an infection. Of course, treating ahead of time with antibiotics before, a confirmed infection is there. That's a standard of care. That's normal. But what I think sometimes we run into is we're treating these things over the phone without actually looking at the urine. That tons of my patients who are here for recurrent UTI, they actually have never had a documented UTI, but they've taken antibiotics, 10, 15 different times in the year. So the first thing is to leave a urine sample. It's like making a paper trail. If every time you feel like you have a UTI, you don't, it's not actually an infection, that's the only way that you'll know the difference. And at some point, you'll sort of say, okay, this is what I felt that last time when the culture was negative. So I know that this is not a UTI. This may be a pelvic floor disorder, like perhaps just urinary frequency, urgency. Sometimes when it's associated with pain, that can be a bladder pain syndrome like interstitial cystitis. But the truly only way to know that is to have documented urine cultures that are negative multiple times in a row to say, okay, this is not a recurrent UTI. This is just a pelvic floor disorder. When I say just, I don't mean to minimize that, but I mean, it's not something that should be treated by antibiotics.
Definitely agree. And I think those are very wise words to everyone listening. All right, let's get to another question. How can you tell what kind of prolapse is occurring?
Okay, I wonder if this is from a provider or if this is from a patient, but this is, I wish I had a slide of this up, I don't, but there's a lovely tool called a POP-Q tool, POP-Q tool, where it's what I do with every prolapse visit. I have a patient who I'm examining and I ask them to strain or bear down or cough or whatever way makes the bulge come out the most. That's what I do. And what I do is measure 9 different measurements while the patient is straining. 2 of those measurements are the top wall of the vagina, kind of where the bladder sits just on top. 2 of those measurements are the apex of the vagina, where either the vaginal cuff is, if they've had a hysterectomy, or the cervix, and what's called the D point or the posterior cul-de-sac. I measure those 2 points. There are 2 points that are for the bottom wall of the vagina, where I measure those with like a little popsicle stick is all it is, with little measurement points on them. I measure the opening of the vagina at maximum strain, as well as the distance between the vagina and the anus at maximum strain. And then the 9th measurement is the total vaginal length. So what I do during the exam is I support different compartments while I have the patient strain. So what that means is I use like a half speculum or something like that to lift the apex and see what happens when they strain. If nothing happens, the prolapse is from the apex. If you're supporting the apex and the bladder is still coming down while the patient's straining, that's a cystocele, that's the top wall, and likewise for the bottom. Sometimes, there's actually no vaginal bulge, but the patient still feels a bulge. That is captured by the other measurements like the opening of the vagina and the distance between the vagina and the anus, something called a perineoceal, where the whole pelvic floor just balloons out. So it's definitely experience, I think, is a part of it, but there are pretty reliable tools that exist, in patient care for us to delineate between those two. And the reason it's important is because the surgeries are completely different. And so what we see a lot, unfortunately, for patients who see non-subspecialists and maybe had a surgery, is they had the wrong surgery. And so maybe they had a surgery to lift their bladder, but their bladder was never the issue. And so, they're coming in with a rectocele that never got better from their prolapse repair. And, it's kind of like, no wonder it was the wrong one. And that we're trying to stop that from happening by kind of doing these sorts of things where the patient gets the right care the first go round.
So just to emphasize, so if a patient is themselves trying to figure out what kind of prolapse it is, your provider.
Your doctor, yeah. Yeah, so thank you for making that very clear, Mira. See if it's, because it's almost impossible to tell yourself. And even if other physicians have a hard time telling, like, primary care, people who just don't do this every day like we do,
right.
It should give you a better answer that it's not for you to figure this out. It's extremely difficult to find that, because they all feel the same. They do.
Definitely. So in following up of when is a good time to see a urogynecologist or rehab when undergoing cancer treatment for GYN cancer, I know you mentioned there are different times that might be best to interact with treatment, but when is a good time to come see someone like you?
Yeah, for someone like me, and Mira, I'll let you answer, for your specialty, but for someone like me, early is a good answer there. It doesn't mean that, we're going to initiate treatment right away, but at least we could sort of map out a bit of a plan based on maybe what your cancer treatment might look like, and, how we can time things. And when we think about surgeries, it's not like we're agreeing to do a surgery and the next day we're in the OR. A lot of times it takes weeks and sometimes months to do some of these things. And so if we know that, you're going to have your cancer surgery that's booked on whatever date, the earlier you can come see me, the better, a urogynecologist can make themselves available to, if you do need a joint surgery. Maybe you don't, but you wouldn't really know that until you were to see a urogynecologist. So I'll say as early as possible, and that's especially critical in patients who are undergoing cancer treatment.
Great. And then in terms of therapy, we would, if anyone is having a surgery or radiation, we would definitely wait at least 6 weeks. But your provider would know best, and as you mentioned, have a plan of care as soon as possible. All right, so talking about timelines, is there an optimal window to receive care for a pelvic floor disorder? Is it ever too late to repair a pelvic floor disorder experienced as a result of cancer treatment?
It is never, 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 never too late, ever. I would say even the bigger question is it too early? And there is a too early, definitely. We don't ever treat, for pelvic floor disorders, we don't ever treat for what may happen. It's not sort of, there are certainly preventative things that can be done. We've talked about those things, but we don't do a surgery to maybe prevent, leakage in the future or something like that if you have no other problems. So it's never too late, but if you're going to have a surgery or have an intervention, it needs to be for what your bother is currently, not for what you fear it may become, because sometimes it doesn't get worse and it just stays exactly the same. So I think I've said that 5 times today. If your symptoms stayed exactly the same as they are right at this moment, are they bothersome enough to do something about? And if the answer is no, then no, we shouldn't do anything. Oh, I think I'm frozen. Am I frozen?
I can hear you again.
Okay.
All right, excellent. Let's get to another question. So you did touch on this, but I definitely hear people having a lot of questions. So if we can highlight, is there an association between vaginal estrogen and cancer?
Yeah, so thank you for asking that. And there's so much literature about this, and I think when we have folks coming from two different sides, at some point we have to meet in the middle somewhere. So yes, there's always an association between estrogen and hormone sensitive cancers. It's does the preparation and the delivery of that estrogen increase your risk for a recurrence or an occurrence of that cancer? And the American College of OBGYNs, or ACOG, they have a committee opinion where basically it is a synthesis of a bunch of different papers as well as experts discussing the topic. And from the available literature that we have, using low dose vaginal estrogen as prescribed, right? Of course, you can use an entire tube and overdose. That's certainly a possibility, but using low dose vaginal estrogen as prescribed has not been shown to increase the risk of cancer recurrence. That being said, as I mentioned earlier, the threshold in the blood of estrogen, in terms of how high of estrogen do you have to have in the blood to cause a recurrence of cancer, that threshold is not well known. And so, how do we know, how much estrogen to give and things like that? And what I will say is, as I mentioned before, if a patient has an oncologist, a medical oncologist who's actively managing them, I will always consult with them, because while the literature says one thing, if that oncologist who was treating that patient in front of them said, well, Miss So-and-so's cancer is a little different, I wouldn't venture at all to give her vaginal estrogen, then that's what it is. But I'll tell you, in doing this for a while, I have maybe had that happen once. Almost every medical oncologist I've talked to has said low dose vaginal estrogen, I have no problem with that, even in a patient with a hormone sensitive cancer. So I do think it is definitely a conversation that needs to happen, but from the available literature that we have, we don't think that it increases that risk.
Thank you for clarifying that. All right, another question for you. After undergoing surgery to repair a prolapse, what is the likelihood of it prolapsing again?
Great question. So it depends on a lot of patient factors, a lot of surgical factors. But when we talk about native tissue repair, so where we don't use mesh, those are all done, not all, but mostly through the vagina. And in general, you can do a native tissue repair for any type of prolapse. So it doesn't have to be just a little bit, it can be a lot, meaning, stage 4 all the way down. But that type of thing sort of lends itself to how likely is this to recur. So for example, if somebody has very terrible stage 4 prolapse, everything's all the way out, and they're very young, in their 40s, sometimes I can tell you, maybe your own tissue is not really great to use again, and maybe really you should use a mesh. But that is not something that is standard. That's not something that's studied. That's not something that someone has said, for stage 4 prolapse in 40-year-old women, you have to use mesh. That's not in the literature. And so when we look at the available literature, it just says, these were the patients, this was their age group, this is the surgery they had, and this is the risk, the recurrent rate of pelvic organ prolapse. So I say that preamble because this is actually a bit of a complicated topic, because what does recurrence actually mean? Does it mean a doctor looks in your vagina and says, okay, there's prolapse, or does it mean you feel it? And I think by all means, like, if you don't feel it, it doesn't really matter. I mean, it's something that we record, but at the end of the day, we are a quality of life specialty. And if you don't feel it, that's considered a success. So when we look at native tissue repairs, the ones that I had in the slide, actually I can go back, I think, just so you have a visualization. So for a uterosacral ligament suspension, that top one, or sacrospinous fixation, the bottom one, the recurrence rates are pretty similar. So there was a trial called the Optimal trial that it only looked at 2-year data, but it's the best data that we have that's looked at these. But at 2 years, 85% of women were happy with their repair. So 15% of women were not and experienced a prolapse. That's a composite failure. When you look at the objective failure, which is the doctor looked in the vagina at 2 years and the prolapse was back, and recurrent prolapse, what is that? It was basically that any part of the wall was approaching the opening of the vagina. It was more like 65% of women had success. So not that 85% that felt good. It was actually only 65% had anatomic success. So since that trial, people have started to look at this a little bit more closely, because what should we even be studying at this point? Does it really matter what a doctor sees 2 years later, or does it matter if the patient's happy? The other kind of landmark trial was this trial called a CARE trial that looked at sacrocolpopexies. It's a robust study, and it was, a lot of patients. However, the type of mesh that was used for sacrocolpopexies at that time is different. The way the procedure is done is actually very different now. But when we looked at nine-year data in the CARE trial, a sacrocolpopexy where we used mesh was about 85-90% effective. So, this is always a question that I get from patients every day, as you can imagine. And it's not really the most straightforward answer. I can't say, oh, if you had this type of procedure, the risk of recurrence is 10%. There's just so much more nuance to that, because it's not like a cancer recurrence. It's either you have it or you don't. This is not like that. So, I would say overwhelmingly so, people are very happy after their prolapse surgery. The risk of it coming back is always there, because you're always going to be upright and have gravity working against you. Even with a mesh procedure, it's always there. But in general, it's low. And in both of those studies, when you looked at who had another surgery for prolapse, it's less than 5%. It's about 3% or less. In the CARE trial, it's about 1%. So not a lot of people actually were bothered enough to have another surgery for a prolapse.
Thank you so much, Dr. Ford. Another question for you. Is there an association between prolapse or pelvic floor disorders and cancer risk?
And cancer risk, meaning developing a cancer. That's sort of what that is?
Up to your interpretation.
Okay, I think, yeah, I know you're just reading, Mira, sorry. But this is actually a question that we get a lot is, if I don't do anything about my prolapse or my incontinence, will something bad happen? Like, will it turn into cancer? And the answer is always no. This is strictly a quality of life thing. I would say, when prolapse gets really advanced, and, sometimes women can have a hard time emptying the bladder, urinary retention and things like that. Well, they're not cancer causative. They can certainly lead to serious health risks like kidney failure, recurrent infections, that type of thing. But there is no relationship between prolapse and causing a cancer, certainly not.
Thank you, Dr. Ford. I'm combining two questions here. How can you tell if your pelvic floor is strong, and what are the benefits of practicing regular Kegling?
Okay, so how can you tell if your pelvic floor is strong? It's sort of like if you don't notice, it's probably fine kind of a thing. It's funny because as a young person, maybe before having babies or things like that, you don't notice. You pee, you have no problem. You poop, you have no problem. You have intercourse, you have no problem. Your pelvic floor is probably strong. The way to really know, I guess, is seeing a physician and having an exam, or seeing a physical therapist and being examined and asked to do various exercises and seeing if you can do those. That is, I guess, the strict answer. But in general, if you don't notice you have issues, it's probably strong. And then tell me again the second part of the question. I kind of got on a tangent. The second part of that question that you just asked. Oh no, Mira.
I'm sorry, I couldn't hear you for a moment there.
That's okay. I had just asked you to repeat that second part of the question.
Oh yes, what are the benefits of practicing regular Kegels?
Oh, okay, lots. I think, that's a part of, keeping the pelvic floor strong, but I think what's more important than regular Kegeling is correct Kegeling. And that's a lot of times where the issue comes into play. So again, seeing a physical therapist or seeing somebody who can ensure you're doing these exercises the correct way is more important than anything. And so, I can let Mira, you can answer a part of that question too, of course.
I think you're exactly right. If you're doing them, you want to be doing them correctly, but I definitely see this in my practice, and I imagine you do as well in yours, which is that sometimes people's muscles are too tight, and you don't want to strengthen a tight muscle that might lead to pain, incomplete bladder or bowel emptying. So like you said, if you're not having problems, great. If you are, don't just assume that you need to do Kegels.
Yeah, that's a great answer. I totally agree with that.
Awesome. Going back to prolapse, is the surgery outpatient? What is the recovery time like?
Yeah, all of the surgeries that we do are outpatient. The recovery is actually pretty similar for any procedure, and it's because it's more dependent on your body sort of scarring the prolapse repair into place. So we typically say, this is changing, but we typically say for 6 weeks after surgery, I say, and don't lift more than 15 pounds, nothing in the vagina, and nothing, no sitting in water. I say things are changing because this year, actually, is it this year now or last year? I think it's last year now. A good paper out of Northwestern and Chicago came out where they let some women, half of women, just do what they wanted after surgery, basically listen to their body. And the other half of women, they kept on pretty strict restrictions. Instead of that 15 pounds, it was a 10-pound weight limit. And they both did the same. I think it sort of lends itself to the fact of like women kind of know their own body typically and what they can and can't do. So I think maybe I'll start to loosen that up a little bit, but I think it's nice to at least have like a baseline. But it is at least 6 weeks of sort of taking it easy and not really exercising a whole lot, just giving that repair time to really just scar into place. So we're not relying on stitches that will ultimately, dissolve. And they're all definitely outpatient procedures. Yeah. Great.
And then do you accept insurance and or Medicare?
Everything, yes. Medicaid, Medicare, this is not cosmetic by any means. This is very well covered by insurance.
Awesome. Thank you so much, Dr. Ford. This has been so great. Hopefully everyone learned so much to share as well with their family and friends. This is also important. Do you have any closing thoughts or words?
I really want to reiterate my gratitude to everyone here for just giving me the platform to speak about this. And to make sure, again, I want to go back to the fact that patients, really be your own advocates. These are embarrassing issues. These are things we often want to keep private, even from our own family, our own friends. There are people who this is literally all I do. I do nothing else but take care of these things. And if you can talk to one doctor, I don't care if that's your dentist or your whoever, and just let them know you're struggling, they can find us. So, or find, somebody who can take care of that. It's not something you have to live with. It's not something you have to keep to yourself. It can be fixed.
Thank you so much, Dr. Ford. I'm going to pass this back to Katie Armsby with Cancer Center Community Atlanta.
Thank you both. That was such a great presentation. And I want to thank everyone for entering so many good questions into the program chat box. It was a really informative conversation. Again, I want to thank Dr. Ford for being so generous with your time and expertise today. If anybody wants to connect with Dr. Ford, I of course encourage you to visit their website, advancedgynecology.com. And again, to visit Northside Hospital's website for more information about the rehab services available. And if anybody would like a recording of this program, we encourage you to visit Cancer Support Community Atlanta's website. Ours is cscatlanta.org. So wrapping up, thank you both so much for being here, and everyone take care and have a good weekend.
Thank you.
Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.